Welcome everyone to Innovaccer's webinar, Key Drivers to Building a World-Class Patient-Centered Healthcare. Thanks for joining us today. We're very excited about today's presentation, and I would like to introduce our speakers, myself, David Nace, Chief Medical Officer at Innovaccer, and prior Chair of the Board of Directors of the Patient-Centered Primary Care Collaborative, and also Paul Grundy, founding President of the Patient-Centered Primary Care Collaborative, and also the distinguished healthcare leader here with Innovaccer and Head of Healthcare Transformation for Health TeamWorks. Welcome, Paul. I really enjoy that you've joined us today, and this will be an exciting webinar.
It's great to be back with you, and we're going to have really interesting time. I hope there's some great questions.
Absolutely. So for those of you who joined episode number 1, we're going to briefly do a recap of that, and then we'll move into today's episode, episode 2, Key Drivers to Build a World-Class Centric Healthcare System. As we move through the webinar, please enter any questions that you have into the chat box, and when we get toward the end, we'll be able to pull those questions and answer them. You will all be on mute, so we won't be able to hear you, but the chat box will be the effective way to communicate with us. So with that said, let's get started. So last month we did episode 1 where we really talked about how do you empower primary care physicians and their team at a point of care? How do you collect that information and provide it in an actionable way to the physician while they're seeing patients and working within their EMR? So what we do know is that primary care really should be the chassis for any healthcare transformation we're going to engage in as we move into value-based care. It really is the first touch point for patients because they have a deeper connection with a trusted advisor. It's far more affordable. Primary care has been shown that over and over again, and it needs to be more accessible. And to do that, we really need to transform our healthcare system and really focus on building a trusted relationship with the patient. Paul, I know that when we were at the Primary Care Collaborative, you were able to really do a lot of effective data and information sharing to show the effectiveness of primary care. Can you give us a brief recap of that evidence?
Yeah, so it's really a no-brainer. When you proactively manage a population, you move from an episode-based of care to proactively managing the population, aspirin, blood pressure, cholesterol. You really can impact the cost of care. You can impact the days of hospitalization. We literally had 1/3 less need to do hospitalization when somebody was proactively managing the population, and we literally had 1/3 less need to do heart surgery when somebody was preventing that heart surgery from being needed. So it's a no-brainer to really begin to proactively manage the population. That was the change of covenant that the businesses asked for with the providers of care.
So we've known that as a healthcare industry for some time now, and we've started to embark on this transformation. And in our last session, we really talked about how it's important to really build trust with patients to influence them, to have a holistic patient record of all the information that's being prescribed by other doctors, by patients seeing different ERs, going into the hospital, having laboratory information, having all that information available to a practice and their team with a 360-degree view of all their information, having that data be real time. So when you're seeing a patient, you have up-to-date information, and also, and we're going to talk about this today, having access to social risk data, because we know that the social determinants of care are a huge driver. And real time today is we know that opiate prescription is an increasing problem. We need that data from multiple sources so you can see all the different people that are prescribing for a patient. So being able to really empower a practice through the use of technology, having automated care management, and having actionable analytics are the key to transformation. And we'll get into that today, focusing on how do we think about patient care, patient information from a patient-centric perspective. How do you truly build a world-class patient-centered healthcare? So if we look at some of the data that's available, we see that patients are increasingly wanting to get care when they want it and when they need it. We see a boom in urgent care centers, but that's a problem because those urgent care centers are not coordinated and connected to the rest of the healthcare system. We know that practices can use modern technology by using more video visits and e-visits, and yet we haven't seen full adoption by practices. They're beginning to do that. So we see this growth in innovation with more real-time virtual care, virtual visits, but there's a lot of work to do to get there. And if we think about what patients want, and this is a survey of what patients want from their healthcare system, we know they want to be able to access same-day appointments. They want to be able to use asynchronous communication between their providers in a 24/7 availability. They want extended hours. Sometimes they want to come after work. They want to come on the weekend, and their practices often aren't open. And they want to be able to go in and schedule care online at their own convenience. So we're going to talk today about how we really address these challenges. And we think about, what do patients really want from their physician, from their practitioner? They want someone who listens, is attentive. Of course, they want somebody competent, but they want someone who's empathetic and understands them. They want to build that trust so they feel they can be open and shareable in terms of all their needs and really define their own goals and have people understand that. So we'll get into that today. Paul, can you talk a little bit about sort of some of your experiences in the past of addressing these challenges?
So when we started this journey in the corporate world a decade or so ago, we did a big survey of our employees. We sort of called a jam. We did a 3-day interactive phase with them. And what we found was that only 26% of our patients could access their primary care doctors after hours. They really wanted a trusting relationship with the healer, but less than half had that. Although when we asked them, who do you trust most in your life, they would say their family and next their healer. They really wanted to be able to effectively interact and communicate with the doctor. But when we sort of tested them after they'd done a doctor visit with some of our own employees, we found that about 60% of the time they really didn't know what the doctor had told them. And they really wanted their care coordinated. One of my employees at the time in this jam said that they were the care coordinator for their mother, and it was a box in the trunk of their Toyota. So we really need to do a better job, and we need better technology to help follow up and follow through and coordinate more effectively.
That's absolutely right. And there's a great story. I don't think I'd want to have my medical information transported in that way. So let's talk today about how you establish a patient-centered practice and continue to innovate and improve your practice in light of these challenges. So if we take a look at the best way to really understand your patients in your practice, ask them, survey them. A lot of practices historically haven't done that, and those that do find it an eye-opening experience. So from the patient's perspective, being able to understand how the practice is currently serving their need, where they want it to improve, and what they can expect from their care team is so vital to really understanding your population. And to do this, you have to do it in an honest and transparent way. Be willing to take the risk of having patients tell you exactly where they see the challenges in your practice, have an open exchange of ideas, maybe build in an advisory team that comes in of your patients that really want to give input and empower them, and really help your care teams become more confident in managing a population, driving more effective interventions. So with that, let's take a poll to see where you all see your practices, your healthcare system, in terms of areas that could be improved. So let's go ahead and start the poll. And in the meantime, Paul, would you like to say a little bit of words about your experiences in this light?
So we actually, working with the Future of Family Medicine, Peter Anderson and I actually wrote a book to address that. We wrote a book called Lost and Found, designed to give to the practice advisors, to the patients who are going to advise the practice. And then we had a children's author rewrite that at a sort of 10 or 11-year-old level, and began sort of handing that out to practices that were incorporating patient advisors on their panel. That was a pretty interesting experience. Anyway, the book's named Lost and Found.
That's great. I think we'd all love to go on to Amazon and see if we can get a copy of that book. It would be very enlightening. So as we continue to get the poll, let's just take a few minutes to enter your responses. And as that poll wraps up, we can go ahead and bring in the results. I see the information is still streaming in and people are still sending in their responses. So let's just give it a few more seconds. We've got about 50% answered. Okay, let's go ahead and bring up the results as they are so far. Here they are. So let's see. 26% feel that you could actually streamline your patient engagement in outreach, so that would be more effective. And then equally, we see enhanced access to care, a better digital experience, a lot more interest in innovation, enhanced patient-provider relationships, perhaps as a result. And some folks, interestingly, not too many about support from community healthcare services. I find this interesting. Paul, what do you think?
Yeah, I find it very interesting as well. I think that particularly in this era of information technology, there's a lot of desire with the millennials to do what the panelists really begin to streamline this, to begin to affect engagement in an e-world more effectively. I think that's interesting result.
Cool. Let's move back on to our presentation. So, we've talked about the importance in this modern era of really getting data to understand a patient population. And as I mentioned before, and in our last session, getting that 360-degree view where you can get the information from all of the people providing care, all of the hospitals, the health systems, the laboratories, the pharmacies, getting that information in a 360-degree view, but then more importantly, collecting that data from the patient, not just in regard to the practice, but in regard to what their needs are. Because we know every patient's different, so are their needs. And there's been this movement toward personalized care because we know that's also from a genomic perspective as well. So catering to patients' needs, making things convenient, making them goal-oriented around their individual goals, understanding their community, and understanding their genomics is so important to gain a better understanding of the patient. So Paul, would you like to share a few stories about your experiences with having data and having that information and also being patient-centered in your practice?
Absolutely, David. I think that what's really interesting and exciting is that I think data is going to do for doctors' minds what imaging and x-rays done for the vision. It's going to make it much clearer on how you have a plan and follow up and follow through with your patients. But when I visit doctors today, it sort of almost breaks my heart. It's so difficult in this early period of getting at the data. This is a drawing below of a 7-year-old visiting their doctor with the patients on the exam table and the doctor's back to them typing on the computer. I think it's just incredibly frustrating, and places where they're beginning to get away from this, they're beginning to figure out how to have a team approach and to have the MAs do the scribing and other elements. But I think pretty shortly, we're actually going to be able to do this in a much more automated way, perhaps just capturing the voice of the patient and the doctor and making file and getting that data into the record. But I'm excited about the possibilities coming down the road.
And I know you've had an interesting experience with your own travel, so let's talk about that.
So I was on a flight probably 10 or 15 years ago on Korean Airlines, and the stewardess came up to me and asked me what I would like to drink, and I told her. And just last year I was on another Korean Airlines flight, and the stewardess came up to me and by name said, "Dr. Grundy, do you still drink the same drink?" That's marketing, and I think that's really important too, to put on the top of the screen the elements that you really need to engage the patient with. And again, I think the tools are beginning to come online for that.
That's a real sea change, Paul, around how practices think, right? So historically, I think practices have been very practice-centered. People come to them when they make an appointment, and that's the event. But now we have to think about how do we engage people, and that marketing perspective is so important. I know in the old days, the way we address this is, we try to collect information about the patient's birthday and their son and their daughter, and are they going to college? So when you pick up the chart on the front of the door, you'd have that information and make people feel really personalized, so you truly understand them and their needs and their family and their orientation. And now we can do that with data. And I think that's a great story, because as time moves on and we have more people playing a role within a care team, each of those folks should be on the same page and have that consistency to the patient. So great story.
And with AI, David, it's going to be possible, just like happened to me when I was coming home from Heathrow from the hotel. I mean, on my screen, the information that I needed without me asking was available to me. It knew, because it was smart. It knew when my flight was, and it mapped my request to the airport, to that flight. So I'm excited that we're going to be able to be much more effectively engaged with our patients with this new world we're entering.
Absolutely. So as a case study, I'm going to share a little bit about one of the Innovaccer's clients. It was our first client, and that's the Mercy Health Network. It's really a network of ACOs across Iowa. And so, integrating all the information from all these different practice sites really was a challenge, right? Patients sometimes went to different hospitals, they'd go to different ERs, they'd go to different pharmacies. There was a state Iowa Health Information Exchange, but that wasn't real time. And so it didn't have the information from the electronic health records either. And if you looked at all the practices across the state as they think about managing a population of patients, they really needed to integrate the information from all the electronic health records of all the practitioners involved in the network to really truly understand the population, identify risks, stratify patients, think about who are the important people to coordinate their care. And in order to do that, we've been able to create a data platform in which we've been able to integrate all the information in real time across the electronic health records, regardless of what type or brand of EHR they're using, integrate the information from the Iowa Information Exchange, bring in all the ADT informations and notifications from the hospital. So when someone goes to the ER 2 or 3 times, the practices and the system, the network, know that that patient's at a higher risk and they can address it. And then having that information across all the different payers in the area is so important, because you really, if you're going to address the population, you have to think about integrating that information with the community. So it's a great example of delivering data-driven care. And the important role as part of that team is having an effective care coordinator, someone who can actually reach out and see that somebody's been in an emergency room and think about effectively managing their transition of care, as they should notify the practice should find out about what's going on. Someone's been hospitalized and they're coming out, making sure they quickly get seen. One day they need 24/7 nursing care, and the next day, historically, they may not have an appointment for weeks. We really need care coordination to bring them into the practice immediately, look at what that care plan was, and help to prevent rehospitalizations and inappropriate ED use when it's not needed. So having this care coordinator role is so important. Having the data to manage that is critical. I know that you've had a lot of experiences with building trust with your patients with that data, Paul. A few more stories, perhaps.
So interesting. In my time as a healthcare ambassador for Denmark, I've spent quite a bit of time in Denmark. And what they do in their first class in medical school is how to build and establish a relationship of trust with your patients over a lifetime. And every patient knows the name of their primary care doc. They've really done an amazing job. Going back to Iowa and your visit to Iowa, I visited a practice in Iowa. This lady is now the vice president of executive physician satisfaction with the AMA. And she had a most interesting concept. When I met her in her office, she said, I do 2 things with my time, Paul. I do difficult diagnostic dilemmas, and I do relationships. And our first patient was a 84-year-old nun. And she had on her record the question that she needed to ask, that day, which was, how is your didgeridoo lesson? They spent a few minutes talking about didgeridoo lessons and then said, you're going to go with my care coordinator and have your diabetic plan mapped out for you. Beautiful plan, really organized. And I said to that nun, how do you like your doctor? Oh, I love my doctor. The patient's MA, I mean, the doctor's MA comes back in the room and types in the computer the cat Millie, which is probably the question that was going to be asked next time. But I love that concept of, I really do two things with my time. I have a team that does everything else, difficult diagnostic dilemmas and relationships, but I always spend at least a minute blessing a relationship of trust.
That trust is so important. And I think with today's healthcare system and the growth of urgent care centers and retail clinics, people seeing multiple specialists who aren't coordinating care and aren't effectively transmitting their own care plans and interests with the patients, that we really lose that trust. And rebuilding that trust from a primary care perspective is going to be so important. We know that being able to have a system of care, an electronic data system that can keep that documentation and have it go available to all the people seeing the patient really is so critical. I know in Mercy in Iowa, there was a 60-year-old veteran with a long history of cardiovascular disease who had increasing alcohol abuse, which was a serious problem. And what they did is when they effectively found out that this patient was increasingly going to the ER, sometimes with alcohol toxicity, and trying to figure out, geez, they're very high risk given their cardiovascular disease. They were assigned a care coordinator. And over time, that care coordinator increasingly built trust with the patient, talked about an effective strategy to manage their alcohol abuse, get them into the right social engagements in order to address that, the right treatment. And after a few months, because of that trust with the care coordinator, the patient's alcohol use dropped and admissions to the ED dropped significantly. And so we see this issue of building trust as critical, and having real-time information is important in order to effectively engage the patient. Well, I know you've had some experience around this regard.
So a case that comes to mind is a diabetic in Virginia that had a bit of cognitive disorder, and this patient's diabetic management was done in the emergency rooms. He would end up in a hyperglycemic or hypoglycemic event and be hospitalized on average of 5 to 6 times a year, running up over $1 million worth of cost over the years. And just like your example of the alcoholic in Iowa, once they got a care coordinator on top of this, once they began to get at the data from all those emergency rooms and bring it together, the last time I checked, and it was probably about 6 months ago, this patient has not been back in the hospital since. They really manage effectively this patient in an ambulatory environment, with the appropriate interaction and care coordination.
And there's so many different people that have different roles in taking care of patients, different areas to address. Most practices aren't significantly knowledgeable about how to address alcohol abuse, but the physician may understand cardiovascular disease. So the use of a care coordinator to engage the patient with those people that are really specialists in treating alcohol, getting them engaged in community resources such as Alcoholics Anonymous, if that's what the patient chooses, and then being able to coordinate that information with the physician really brings about a new way of thinking about addressing these complicated problems. So if we think about access to patient records, today we're in this age of information, right? So we have electronic health records in all the practices and all the hospitals, but the clinician can only see that data that their practice has entered, or that data that is available within that hospital. It's incomplete. The patient may be seeing a couple specialists, and in the last case, maybe a cardiovascular physician, or it could be a therapist who specializes in alcohol abuse, but they're recording data in different areas. They're not coordinated. What we need to do is we need to move into this age of intelligence, where we have integrated information so that every clinician can see not only the information across the spectrum of all the people taking care of that patient, but also having that data turn into real intelligence, showing the gaps in care. What does the clinical evidence show that are the effective interventions that can be done for that patient given those gaps? Having real-time information so that when the patient presents in the emergency department or has been hospitalized, the physicians and all the practitioners are notified of that immediately so they can act on it from a care coordination perspective. So moving from this age of information into the age of intelligence is the next stage in digitalization in this country, and we're very excited about it. Now, Paul, I know that when you were at IBM, you did some work in Denmark and you got some exposure to the Denmark system. What are some of the lessons you learned working in Denmark?
Well, first of all, I think the most important lesson that I learned is that they really focus on a trusting relationship between the healer and their patient. They build on that, but they also have one of the most innovative technology systems where every patient has a portal, and by law, all of your records are in that portal. So you give access to your GP, and that then gives you care for free. And if you elect not to do that, you pay 10% of total cost. But that allows any primary care physician to cover for any other primary care physician. I was at a restaurant in Copenhagen, and one of my employees was having dinner with me, and I said, if you needed help, what would you do? And they said, I would just call my GP. And they would answer, oh yeah. So we said, let's try that. And they did. They called the GP, and within 2 minutes, we got a call back, and it says, I'm Dr. Hans. I'm covering for Dr. Hannes, and your doctor really cares about you and wants, but the first thing he asked was for permission to access those records. It's really interesting. I'm sitting with a patient who needed a heart valve replacement, and the doctor was able to bring up every place in Denmark that did heart valve replacements, the morbidity, the mortality, how far away it was, and how long the waiting list was. It's really helpful if you can pull all the information together, and beginning to see that happen in many places in the United States now.
Yeah, I think I remember you were sharing a story once about a physician seeing a patient and how they were in real time able to connect to the pharmacist to have a consultation while they were in the office. It's truly exciting. It's truly exciting when that kind of technology is available. So that brings up this issue of, automation and technology being the key to patient-centered care. Sounds like you learned a lot of lessons in Denmark. How does that extrapolate to your vision of how automation can really help us going forward?
And I think if we can take some of the tools that have been developed in AI with millions of information inputs and patterns, I think it's going to be really possible to have a system in which your patient is told ahead of time about the appointment, has a chance to input information, a chance to understand what's going to happen. Again, this sort of automated just coming out of the records. Pretty sophisticated understanding beginning to happen. For example, a woman with 3 children, the best time to get a hold of them and get them to respond is Tuesday evenings after 8, for example. But beginning to understand those kinds of patterns, which are now used by Google and others, getting that into the hands of the patients, and then having your records when you visit, and then a follow-up after you visit with what just happened to the patient. Because again, 60% of the time, patients don't remember or don't know really what happened in their primary care practice. I think those kinds of elements are going to really make it different and make it automated. I mean, my cat gets notified it needs its immunizations, and that's an automated system. We can at least do as good as that.
Yeah, I think about my own experience seeing patients. Before the age of the kind of communication platforms we can build today, and as you mentioned, artificial intelligence to really bring intelligence. I would see a patient, we would talk, I'd have 15 minutes. I think today it's maybe 10 to 12. And so as they were leaving and they put their hand on the doorknob, I always referred to this as the doorknob phenomena. They would open the door, turn to me and say, oh, one more thing. And then that ended up being the most important issue that I really needed to know. And it's so funny because it creates anxiety because you've got patients stacked up, and here we are at the end of a session and the patient's saying, here's something really important I didn't bring up for a variety of reasons. And then you have to make decisions. Do I spend another 20 or 30 minutes with that patient? So the key really is being able to have the ability to communicate 24/7, have, as you said, have that automated information coming to the practice so the patient has that experience. And then the other story I have And this is as myself as a physician, when I go to see my own practice, I often get home and think, oh, I forgot to mention these things, or more importantly, I can't remember completely what they shared with me. And so being able to, and I'm fortunate, I'm able to get on to 24/7, asynchronous communication, send a note to my physician or the nurse and say, oh, I forgot, this is what I remember. There was a couple other things brought up, and I get that communication back and forth in real time. So I think having this sort of 24/7 communication, having the electronic ability to have asynchronous sharing, being able to have information before the visit, during the visit, after the visit, and having that be true intelligence where you're getting insights and actionable information, both as a care team and as a physician, as a patient, is so critical. So let's take another poll and have you rate yourself on the effectiveness of your practice's communication with patients for both clinical and administrative purposes. So we'll give everybody, and we've got a lot of people on the call, a few seconds to answer this. And as we collect that information, let's share a little story about automation and AI. Paul, do you have some other thoughts about the increasing use of technology and artificial intelligence in today's world practice?
Well, I have two sons, and they're in their 30s, and I can tell you that increasingly they're demanding that, they've never seen a teller in a bank, they never will. I mean, their expectation is that we're going to engage them the way they engage. And I think that's increasingly going to be important for practices, and the practices that are doing that are beginning to be very successful.
I know it's such a different world with millennials and the younger folks who really are so used to using computers. I often bring up and hold my own smartphone up and say, this is the world we need to enter in healthcare, right? A platform with lots of applications that I can go onto wherever I'm at as I'm traveling and get real actionable information. Think about the way we all use Google Maps, right? We go onto Google Maps, we're getting ready to drive, we can see how long it's going to take us to get there. We start the drive, there's been a car accident on the road, it notifies us, oh, we should make a right and take a different route. Can you just imagine if we could effectively coordinate care with real-time insights and actionable information in that way? I just think there's a tremendous opportunity as we move forward, as we have experienced in Mercy with the health network and other systems around the country, where they're starting to automate the information, use machine learning to be able to make the practice more efficient, use artificial intelligence to start to bring actionable information to the patient. And I think this is really going to escalate. So let's take a look at kind of how folks are doing today. We've got a number of people that have answered this poll, and let's see if the poll results are done. And we can bring up the poll results. There we go. Interesting. So about a third of people feel like their ability to communicate is minimally acceptable. Interesting, not unexpected. Some people feel they're doing a pretty good job, but they could do better. And there are some 25% that either need significant improvement or aren't sure. Only 1% feel there's no need for improvement. Paul, what do you think about these results?
Yeah, what I expected. I mean, I think it's early and primitive in terms of getting at the information we need, meeting the demands of our patients at this stage. And I'm excited that we're able to start getting better at this.
Awesome. So interesting information, very insightful. So let's go ahead and go back to the presentation. So I think the last stage we'd like to sort of get into here is, how do you effectively empower patients? How do you think about really truly engaging? This is a journey we're all in, right? Where we're starting to increasingly mature for ourselves from a physician or practice-centered practice to a system of care that focuses on engaging the patient, right? Because we know the importance of engaging them in their family, their community, and driving sort of self-care. That's the effective way to do it. We need to empower them with information. So this first stage we've talked about, right? How do we effectively use modern technology to increasingly communicate in real time and 24/7 with patients. Being able to have electronic chats with a care team, a care coordinator, or a health coach. Having telehealth so that you can have virtual health. And I know some systems of care have already moved up to almost 50% of their contacts with patients through virtual care or telehealth. And then having text and voice outreach, not just to individual patients, but also to populations that you see at risk. Who are the diabetics in your population? Who are the people with heart disease? And how do you do campaigns to effectively reach out and engage them in making sure they're addressing their needed care and having preventive care, secondary preventive care done to minimize the use of the high expensive healthcare system, which can be very dangerous, going into the hospital at the last resort when things get bad. How do we really engage them? How do we get reminders to them? How do we educate them, provide them with real comprehensive information in sort of self-management? And how do we help empower them around what a care plan is, give input into it, and develop their own plan, and then coach them and effectively help them move into this sort of self-care mode? It really is a difference in moving from a physician or practice-centered care into a patient-centered care. So I want to give an example, and I pulled up here one of Innovaccer's platforms. This is our care coordination platform, to give an example of how today one can interact with patients in this way. So this is an example of a care coordinator. They've just had Joy Larson pop up on their screen because they have their patients identified in priority by their risk. So you can see up in the upper left, this is a high-risk patient. They've had 3 emergency room visits in the past month. So this is a patient we really truly want to engage and make sure we effectively build that trust with. So we have all the information about them. We know they've been discharged from a hospital. We see all the pre-contact information. Again, this is an artificial patient. Just for the use of this particular case, we can see their payer, what kind of insurance they have, their primary care provider, their contact information. So we want to reach out, and so we can connect to them. If you look at that last screen up in the upper right-hand corner, you can see click to begin video call. So patients expecting a call, we click on here and we suddenly have face-to-face communication. So in the bottom left, you see you as the care coordinator. This is not a picture of me, but could be. This is the care coordinator engaged with the patient, and that face-to-face connection is so important. And we see increasingly people are doing this using their smartphone, right? So you're having a communication with the patient. You're talking about issues and challenges they have in accessing appropriate care given their care plan. And you start to say, geez, let's bring in a health coach, or let's bring in a family member if they're available. And we can see over here, we can invite people into this call and have a 3 or 4-way or 5-way call, or maybe it's a physician down the hall that you want to engage. Send them a quick, real-time notification, bring them into the conversation, and really address things as a team. And then lastly, you can minimize this screen as you're talking to the patient or having other people engaged with them, and you can do your documentation and see all the information so that you can be knowledgeable. So this is my issue. I can only remember what's in my brain, and I've got so much RAM. But with a computer screen in front of me, and if I see all the information about a patient, I suddenly look very knowledgeable and can be more effectively addressing the needs of that patient. So just an example of modern technology in action. So with that said, we've talked a lot today about the role of the community, the role of other issues beyond the traditional medical interventions in care. And I know we all talk about this importance of social determinants of care. We want to spend some time talking about how we can effectively address that. Paul, if you could say a few comments about the importance of this issue compared to the way we've traditionally approached care.
Yeah, again, I spend quite a bit of time in Europe, and they spend about as much money on healthcare as we do if you add in social care as well, social services. But they end up spending much less on hospitalization because of that. So Vermont, in their Blueprint for Health, created a model where they took 2 cents out of every sick care dollar, and they created a role of a community coordinator. And that community coordinator pulls together all the resources in the community. They meet once a month. And they kind of map out who can do what for that population. So everybody really has a plan. So my newly diagnosed diabetic is introduced to the diabetic hiking club, is taken down to the grocery store where they do where on Thursdays they have a tour of the grocery store, talking about with a nutritionist how to prepare food. They're taken to to the pharmacist in their local pharmacy, and he sits down with them and tells them how he's going to help with medication management. You know, if there's a coat needed, the Goodwill Industries brought in, etc. They've had amazing results. That community, I went up to St. Johnsbury, one of the 11 communities with this Vermont's broken into 11 communities, but one of those communities, and they've had a 60% reduction in the complication of their diabetes, 60% less blindness, 60% less amputations, etc. And they've really created a plan that goes beyond sick care into social determinants of health for their citizens.
So the question really becomes, I think, is it's opened our eyes into this. I mean, look at this pie chart, right? So if we think about traditional clinical care, what's available in the fee schedule, it really only impacts a little bit around the determinants of health. It's these social and community issues and the behavior of the individual, right, themselves. We know that exercise and engagement in the community, social isolation, so important. I think the question for us all is, given that these are the most influential drivers of health statuses, how do we actually assess the risk? How do we prioritize patients and effectively use this information within the care process? So we were at a conference just 2 weeks ago in San Diego, and someone asked this question, and it was an actual presentation on social determinants of care where they were addressing all the different domains. And someone says, well, okay, well, how do you effectively build this into the care process? And the response was, well, you should engage community services. And the question came back and said, well, how do you do that in the practice? And they said, well, you can go to the local library and find out information about what resources are available. That was not very helpful. And they asked the audience, how many people do this? And only one person raised their hand. So we know and we talk about this a lot, but let's talk a little bit about how do we do that, right? How do we integrate this information into the care process? So if we take a look here, we can understand the data sources that are actually available to really truly understand socioeconomic risk. And if we were able to pull that information in and get patient-generated information data, right, which we can collect virtually, electronically, or as I pointed out before, while they're waiting in the emergency room, then we can actually start to build in a risk factor, right? So here at Innovaccer, we've been able to build social determinants into the care management process by putting out patient-generated data questionnaires through multiple channels, including while they wait in the emergency room or in the office for their visit, collect that data. We can actually connect them to an Uber and then have them have a smartphone and start to answer these questions on the way in. But we collect that information from wherever we can, and then we take that data and combine it with what we know from science to be vulnerability criteria to create a specific social vulnerability index. So traditionally, we know that we think about moving into value-based care, there have been risk factors identified and criteria that haven't looked at these social vulnerability issues, but we need to build that in given that's the bigger driver of care. And once we do that, we can stratify and prioritize patients based on that index, in addition to traditional clinical risk indicators. And then more importantly, if you have all that data around the community resources that you've built a network around, you can start to connect people electronically with those resources. And then the important thing is manage them as a referral process. So just like we do with, and we talked about this in the last visit, where we can refer people electronically to a specialist and then manage that, right? Make sure they've made the appointment, get the information back, be able to asynchronously communicate with that specialist, get their recommendations, coordinate that care. We can now do that with community resources. So we can effectively manage the patient's engagement in community resources and start to address these issues of social determinants of care. So it's really exciting now that we know that that's the big driver of healthcare. and health determination and health status. And so we can start to integrate that into the actual practice.
And David, this is going to be increasingly important as we move from a head in a bed being a profit center to being a cost. You're already seeing this movement in Maryland, for example, where hospitals are capped. You're beginning to see hospitals and systems and healthcare plans really working with social agencies to begin to get at better engagement, better mental health issues, et cetera, to keep patients out of beds. And as the payment changes begin to roll out, it's going to be increasingly important to get at this data to really do some of the things that they're doing in Vermont.
And that's exactly right. Our experience in the Mercy Health Network is that we've been able to effectively do this by not only connecting everybody, sharing the data across the state, having it be real time, having care coordinators who work effectively to build trust with the patients, but also to engage the community, right? So as I mentioned before, we have all this data real time around hospitalizations, ADT feeds, emergency department use. We can improve communication virtually with the patient through care coordination and a platform, as I demonstrated earlier. We can use sort of social media like patient timelines and engage people with their smartphones, with their computers and telephone, and move into virtual care. And then start to address, because we have a system of care that has intelligence, addressing true gaps in care that we can do and manage the population by monitoring the quality metrics to make sure we're continuing to improve the health of that population. And that effective engagement of the community resources is so critical because it is the big driver of health status. So I think that's a nice summary today of sort of where we think about things in terms of where technology and automation can bring us around being a more patient-centered care system. And let's move on to some of the questions. We've had a lot of questions pour in, and we've got hundreds of people on the call. So let's start with the first question. So Paul, let me just read this to you. So along with the care coordinator, have any care providers focused on the psychological side of care management? And the example that I asked was, e.g., how about leveraging hypnosis to help a patient with chronic disease such as diabetes to change their lifestyle for the better? Any thoughts about focusing on the psychological side of care management?
Absolutely. And I visited some clinics, one La Clinica in Colorado, where they really consider every chronic disease a behavioral issue as well. And so every chronic disease person gets integrated with behavior and behavioral management. That seems to be a pretty effective model. The whole concept of I just cannot imagine how your diabetic is going to get better if you don't address their underlying depression, for example. These things are mixed together, but absolutely, it's going to be increasingly important. When you think about two things a physician should do: difficult diagnostic dilemmas and relationships. I think medication management is probably much better handled by a pharmacist, and I certainly think behavioral engagement is much better handled by a professional who is a behavioralist than us, who are really trained to do difficult diagnostic dilemmas.
Yeah, I have two stories to share about that. One is, when I was running a disease management program for diabetes, I had my supervisors for the care management teams come to me and say, our staff are really having a hard time. We hired the best nurses who really have endocrinology experience. They're knowledgeable about diabetes, but they're really becoming fatigued and frustrated with their work. They feel like they're not getting anywhere with these patients. They're on the phone with them, they're calling them, they're engaging them, they're going to meet them at their home, and they're getting down. So we actually looked at the population. We found that about 40% of them met criteria for depression. And I called this the contagion effect, where the care managers were getting depressed because they didn't know how to deal with the depression. They didn't have that experience. And the solution we did is we hired an expert psychologist in depression to put in each one of the pods, to put it with each one of the teams to help work with them when they identified patients with depression. And suddenly the contagion effect released, and the care managers were suddenly bright and enjoying their job because they were being more effective in addressing patients. patients are not diseases. They're a collection of things, and this psychological piece is so important. So next question. How will we manage the interdependence between the need for patients' data and maintaining a trusting relationship in how that data is being used? Example is, it could be used to improve my care, but it may be sold to another organization for my benefit or not. So how do we think about data use policies? How should we think about using that data if we're going to collect it and share it to make sure we keep that trusted relationship with the patient?
And that's much broader than just healthcare data now. I mean, there's a whole issue around that. But again, going back to my Danish experience, we got legislation passed basically that all your information was owned by you. If anybody, and you had the right to give permission for people to have access to that data, and it was what you wanted them to have. And if anybody broke into your records without your permission, they would lose their license and go to jail for 5 years. I don't think that's ever happened in Denmark, but there's also the right to break the glass. If they could document that you were in a coma, for example, in the hospital, and they needed access to your records, you know, but each time somebody enters your record, if you haven't given them specific permission, you get notified. But
Yeah,
by mail, and you know, so I think in some places it's going to require really figuring out how we legislatively handle some of these issues, in my opinion.
and I think from a technology perspective, right, as a country, as a society, we're getting more comfortable with this. So I'll go back to my experience with the smartphone. You know, most people use their phones and they use it to manage their finances, to send money to people, to pay expenses by using their phone. I know I certainly have all this information flowing all the time. It's an issue of having technology with good data governance and good notification when there's risk, as you point out. So we all know this is doable. We all use technology today to manage very sensitive information, and we can now do that in healthcare too. So it's very exciting because we can start to really leverage this technology, but we need to be important that we have that sort of data governance in place. So the last question is, given our time, is how can we determine which communication channels work best for patients based on their age? So we've talked a lot about millennials. You know, we've talked about Joy Larson as an example that I brought up, who was a 60-year-old female. So how do we think about what communication channel works best for patients? Paul, thoughts about that?
Yeah, I think the first thing you do is ask, I suppose, you know, how you would like to be interacted with. I think the second thing is to just try. I know that in one episode that I was involved in, using AI, they would begin to really look at response time, responses, begin to recognize patterns of how people respond. And I know that all the AI companies do that. But I think that, you know, you guys are really beginning to get at those kinds of things with AI in your technology, that can begin to answer some of those questions. But I think the first thing you need to do is just simply ask, how would you prefer us to reach you? By phone, by mail, by email, by text?
Yeah, and I think that goes back to the point we made when we started this webinar is, you know, the best way to really understand your population and your practice is to really start to survey them, right? And it's a big risk to expose yourself and say, how can we be performing better? Where are we failing? Where are we not meeting your needs? And then be able to bring, you know, great leaders amongst your patients who get to know your practice, right? Those people with chronic disease who are regularly seeing your practice, to get them engaged electronically, face-to-face, and say, let's form a council that gives us feedback. I know Paul, I know that you actually introduced me to a practice in Hawaii, and I went out and visited them, and they had been doing this with creating a patient council of 4 or 5 leaders, patients that regularly use that practice, who would get together once a month and talk about and look at data, right, in terms of their own surveys of the patients in terms of how they're meeting the needs, in terms of understanding the community and how to use community resources. You really have to really focus on understanding your population and the communities that they live in to really effectively address them. And then build in this information that we addressed today about social determinants of care. And again, it's so critical to have the electronic communications and the data that's transmitted into intelligence to really help guide you. So we've done a great job today where we've talked about how do you survey your patients in your practice? How do you understand them better and their needs? How do you build a patient-centered information where you have a complete 360-degree view of the patient? How do you think about addressing your patient's needs in the way that they need to? How do you look at social determinants of care and understanding the risk factors and prioritizing patients? And how do you use a technology platform to better coordinate care and engage people with virtual care, right? And be able to meet them with their communication needs and be available round the clock as they need, whether it's asynchronously or by video chat or however you need to communicate. So lots of interest about the way this technology is being used in Mercy at Iowa and across the country. And I think, as you pointed out, Paul, this movement into sort of artificial intelligence is really going to help to make care more effective and integrate these various aspects of care. Any final thoughts, Paul, before we close the session?
Well, just thank goodness that we're finally moving out of the information age into the age of intelligence, because the information age has not worked very well for us in healthcare. It worked pretty well for launching a rocket to the moon and bringing it back safely. But when you complicate that by gazillions more times with managing 100 diabetics, it's much more difficult than rocket science.
Absolutely. Well, I want to thank everybody for joining us, particularly for answering questions. There were many questions that we weren't able to get to. I think if you come back to our next episode, we'll be able to address other thoughts and questions you have. Just as a reminder, our webinar series around the grand transformation of healthcare, particularly with a focus on primary care. Episode 1 was engaging physicians at the point of care. Today's was talking about patient-centricity. And episode 3, which will be coming up in a few weeks, is how do you focus on building a team-based model of care, of having a team work together to deliver primary care effectively to a population as well as at a patient level to meet their needs. So with that, thank you very much for attending today. Our time is up, and hopefully we'll see you on the next webinar. Thanks, everybody, and we will now close the session.